Trends in Modern Psychoanalytic Supervision by Hyman Spotnitz. Part 5. Case illustration, Miss Zee and Ruth. The following description of a series of supervisory sessions illustrates how the supervisor works with an inexperienced analyst embarking on the treatment of a schizophrenic patient. While the case was atypical in some respects, it well demonstrates how the supervisor helps the neophyte practitioner establish contact with a pathologically narcissistic patient. The supervisor, we'll call her Miss Zee, was a well-analyzed clinical psychologist. The patient, who will be called Ruth, was a very bright 19-year-old girl who had already shown much talent as a writer. She consulted a psychiatrist because she felt that she was falling apart. She was in danger of failing in her college studies, she said, and had abandoned a novel she had been working on for many months. She asked whether she could be helped without going into treatment in a formal sense. All she wanted was to have someone listen to her once a week. At psychiatrist's suggestion, Ruth made an appointment with Miss Zee for the following week. In a supervisory session a few days before that appointment, Miss Zee thanked the psychiatrist for referring Ruth to her and expressed eagerness to work with her. Miss Zee asked how she ought to handle herself in the initial interview. She was told, just ask questions. It was explained that she was to listen to the patient in the treatment sessions and ask her a question from time to time if the patient made no attempt to establish contact with her. Brief questions about people or external situations mentioned by Ruth would be desirable. The object of asking these questions was not to influence the patient in any way, but to give her some communication to mitigate psychotic or suicidal reactions. The indication for interposing questions was that the absence of communication from the analyst was producing too much regression in the patient. Since ego-oriented questions were likely to precipitate dangerous regression, Miss Zee was told to avoid them. At the start, the supervisee is given the freedom to report in any way he pleases about a case. For example, from notes written during or after each session, from a verbatim record made during the session, from a brief summary, or from memory. If this method provides the supervisor with the needed material, the supervisee may be permitted to continue to use it. If this method of reporting is not satisfactory, the supervisee's resistance to giving as accurate and full report as he should be giving, in the supervisor's judgment, is investigated. For example, a student who relies entirely on his memory may be asked why he doesn't summarize the patient's material after a session or make notes during it. A student's tendencies to concentrate on his own interventions and skim over the patient's communications may be investigated in a similar manner. But Miss Zee required no help in this area. She proved to be an excellent reporter. From the opening of the case, she presented virtually verbatim records of Ruth's communications. Miss Zee also had a good record of many of the questions she asked the patient, which were well-timed interventions. Thus, Miss Zee made it easy to study the patient and the patient-analyst relationship. In the first 16 sessions, Miss Zee asked Ruth a total of 80 object-oriented questions. Ruth talked more and more freely about her fear of going insane, and in only one of these sessions did she make any attempt to establish direct contact with the analyst. Ruth demonstrated no feeling for Miss Zee. On the contrary, she related to Miss Zee as part of her own mind. This is typical of a patient in a state of narcissistic transference. While Ruth was communicating terrifying material, Miss Zee's voice questions conveyed the impression that Ruth had nothing to be afraid of and that Miss Zee was not disturbed by the content of Ruth's communications. Miss Zee's reactions to these communications were focused on in the supervisory sessions. Despite her excellent control in speaking to the patient, she recognized that she was encountering difficulties in handling the case. She also recognized that if these feelings were not investigated in the supervisory process, she would not be able to help her patient. In her account of first sessions, Miss Zee said that Ruth spoke easily, intelligently, and eloquently about not wanting to be cut off from her feelings, the way her father was, and about being afraid to take risks. She wanted to be more certain of herself in relating to people. Ruth said that she was deteriorating, and she mentioned suicidal thoughts and suicidal dreams that terrified her. On being told of the patient's increasing anxiety, the supervisor asked Miss Zee why she did not ask Ruth more questions in each session. In reporting her initial impressions of the patient, Miss Zee had described her as immediately likable, and had also remarked that she felt like a strong mother with a docile child. Ruth's fright initially had the effect of enhancing Miss Zee's own sense of security. However, when Ruth began to speak increasingly about suicide and psychosis, Miss Zee herself became more and more frightened. In a relatively short time, Miss Zee's anxieties were transformed to some extent into a fear of losing the patient. Ruth began to talk of leaving treatment if there was any danger of her becoming more suicidal or psychotic. Miss Zee derived security from her faithful compliance with instructions not to reveal any of her feelings to the patient. Miss Zee appeared to assume that if she scrupulously carried out these instructions, the patient would make progress. Consequently, it was a big surprise to Miss Zee when Ruth began to talk about leaving treatment. A discussion with Miss Zee eventually cleared up the problem as to why, despite her faithful compliance to object-oriented questioning, Ruth was becoming more disturbed. When patients are asked object-oriented questions by the analyst, they usually begin to ask questions themselves after a few sessions. But Ruth did not try to establish contact with Miss Zee until the 12th session. At that time, after talking about a crisis in her relationship with her roommate, Ruth asked the analyst what she should do. Miss Zee countered with a question, "How will my answer help you?" Instead of answering, Ruth changed the subject. A few sessions later, she asked Miss Zee, "How do you see my situation?" The analyst replied, "How would my perspective help you?" In the face of the patient's developing threats of leaving treatment, Miss Zee was instructed to investigate with the patient why she made so few attempts to establish contact with the analyst. When Miss Zee did so, Ruth told her, "Whenever I've asked you a question, all I got from you was a question. So why should I bother anymore?" In the next supervisory session, it was pointed out that the patient gave up very easily and that the analyst had permitted her to give up. Why? Miss Zee was asked, wasn't she more persistent? This question provoked lively discussion. Miss Zee advanced several objections to this approach. Primarily, she feared that further probing would make the patient very angry and stimulate her to actually break up the treatment relationship. Miss Zee did not relish being exposed to Ruth's sharp criticism any more than she wanted to lose her as a patient. Miss Zee's objections were thoroughly investigated in the supervisory sessions. It was then suggested that even though Ruth had said that she just wanted to be listened to, actually she had wanted much more. Apparently, she did not know what she wanted to secure from the relationship and did not know how to ask for it. From Ruth's early childhood, her mother had anticipated Ruth's needs and met them before Ruth could ask for what she wanted and could assert herself to have them met. Functioning in the same way with Miss Zee, Ruth expected the analyst to sense and respond to her needs and to answer her unstated questions. When Miss Zee failed to do so, Ruth had come to the conclusion that the analyst did not care for her. Ruth was therefore trying to find some way to terminate their relationship. This discussion stimulated Miss Zee eventually to ask Ruth why she did not ask her more questions. Ruth, sensing that Miss Zee really wanted her to ask questions, said she felt guilty now that she had not asked them. Miss Zee then told her that it wasn't necessary for her to force herself to ask questions, but that if a question spontaneously occurred to Ruth, she should not hesitate to ask it. However, Ruth announced during the 20th session that she wanted Ted to drop out of treatment. Reporting her immediate reactions to this announcement, Miss Zee told the supervisor, "I was too overpowered to feel anger or resentment. I felt that I had taken an ASP to my bosom. I was more than ready to give up." The threat was all the more stunning to Miss Zee because Ruth had made remarkable progress during the first 4 months of treatment. Her gloom had lifted and her behavior had improved. She had passed her college exams with very good grades and had spoken of resuming work on the novel she had dropped. Her paralyzing fears and uncertainties were diminishing. She was able to deal more directly with her parents, and they were impressed with the change in her attitudes and behavior. The supervisor encouraged Miss Zee to verbalize all of her reactions to Ruth's announcement that she wanted Ted to terminate treatment. "It's good riddance to her," Miss Zee said. "I've knocked myself out long and not help Ruth." Then Miss Zee continued, "But I must have done something wrong. If I had intervened more skillfully, this situation could have been prevented." The supervisor responded, "But as far as I can tell, you followed my instructions to the letter. All you did was to ask a few object-oriented questions in each session. It is I who am to blame for the patients wanting to leave you." The supervisor expressed his attitude not only to reassure Miss Zee, but also to help her verbalize resentment to the supervisor for having permitted the situation to develop. Various reasons why Ruth might wish to leave treatment at that point were explored. Had Miss Zee somehow or other conveyed the impression that she disliked Ruth? Even though some of Miss Zee's questions suggested that she liked Ruth very much, her strict and rather curt observance of the instruction to refrain from giving the patient information at that time might have given Ruth the impression that Miss Zee did not like her. When appropriate, it might be in order to investigate that possibility. Fortunately, Miss Zee had been too shocked at Ruth's announcement to tell her that she ought to continue treatment. This shock had also prevented Miss Zee from engaging in some other maneuver that might have intensified Ruth's resistance to the point of forcing her departure. However, postponement of the operation of this resistance could be suggested, and this strategy might work. Hence, the supervisor instructed Miss Zee to ask Ruth at the next session, "Why can't we discuss your plan to stop treatment? Are you in too much of a rush to come for 1 or 2 more sessions to talk about it?" When these questions were asked, Ruth did not answer them, but a few minutes later she asked Miss Zee, "Do you like me?" Miss Zee rejoined in a friendly manner, "What would make you think I don't like you?" Ruth took this as an indirect communication that the analyst did like her. Ruth then said that she would reconsider stopping, and she asked Miss Zee to give her a few more sessions. These would help her decide whether she wanted to continue the treatment. The supervisory sessions just discussed covered the first 6 months of a continuing case that began 2 years ago. The relationship between Miss Zee and Ruth has steadily improved, and Ruth's initial resistance to verbalizing how she wanted Miss Zee to help her has been basically resolved. About a year and a half ago, Ruth asked Miss Zee to help her become a stronger person. As yet, Miss Zee has not provided any interpretations because Ruth has evinced no interest in her own personality dynamics, but she has repeatedly asked for general information about the analytic process. Miss Zee has been encouraged by the supervisor to provide this information. Ruth recently said that she is now finding it easier to talk to Miss Zee and get things off her chest. Ruth still feels some tension in the treatment situation, but she has become much more comfortable with it. At times, she actually looks forward to coming to a therapy session. The most important change that the supervisor has been able to deduce from Miss Zee's reports on the case is that Ruth has developed into a much more emotionally aware person. She is now talking about her desires for a husband and a good marriage. Part 6. Duration of supervision. After a series of supervisory sessions extending over a period of 1 to 2 years, the student analyst is usually able to treat neurotic patients on his own. Learning how to deal adequately with a schizophrenic patient may require 5 or more years in supervision. After 5 years of treating such a patient on a supervised basis, the student analyst usually has acquired sufficient understanding of the patient to continue the case without further help. But proficiency in dealing with that patient does not guarantee that he will not encounter difficulties in the treatment of other schizophrenic patients. In terminating the supervisory relationship, I therefore inform the analyst that he is free to return for a consultation when he wants help in dealing with a particular problem. Consultations on this irregular basis may cover a second span of 5 years. The transformation of the student into an emotionally mature analyst capable of treating the schizophrenic patient successfully generally entails a decade of supervisory help. Part 7. Summary of supervisory interventions. In summary, the situation between the supervisor and the student is analogous to that between the supervisee and the patient. By the way he works with the student and, on the student's resistance, the supervisor shows how the student should work with the schizophrenic patient whose case he is conducting under the supervisor's directions. The main problems of the supervisee are approached in the same way as the main problems in treatment. In other words, they are regarded and handled as resistances to the supervisory process. These resistances and their various patterns have to be aroused, picked up, investigated, and resolved through effective interventions. The supervisor intervenes by demonstrating total acceptance, conducting thorough investigations, giving highly specific directions, using joining and reflective techniques, engaging in emotional communications, and communicating understanding. The student who succeeds in communicating appropriately in the supervisory sessions and in resolving his resistances to carrying out the supervisor's instructions effectively usually is able to help the schizophrenic patient mature and become the kind of person he wants to become.